as we mentioned, one of the key elements for all of us, or the struggle, is how to line them up, how to sequence them. And will they sequence based on preference? Will we go by tolerance and adverse events and, of course, patient preference? Or are we going to depend on certain science? And the science, will it mean that only this one showed clinical evidence of better improvement in outcomes, so that's why we like it? Or is it more science, like, for example, we see that this specific option is more beneficial for patients with a specific certain demographics or certain biologic components? Admittedly, we're not there yet, but nonetheless, at the moment, the advent of those combination therapies is kind of like bringing everything into first line therapy. And the question is, do we then squish everything down, and i.e. we call them like line -1, which I'm going to talk about quite a bit today, or and as such we keep sorafenib, lenvatinib, quote unquote, as line 1 or line 2, and then move everything to line 3. And the understanding is, why would you do that? Because in all fairness, these are beneficial drugs. We have tested them right and left, and if anything, we know that they have a lot of value for them. And why not? And why should we take away certain assets that could be beneficial for patients?